morning, everybody. Good afternoon. I just woke up half an hour ago and rushed to the session, the most important session for the managers of programmatic management of drug-resistant TB, because this is a dilemma that many people have been facing and actually has been contributing in some occasions to delay the accelerated access to programmatic management of drug-resistant TB. Shall we provide care and treatment for patients in hospital, or can they really move to ambulatory care? So my name is Ernesto Jaramillo. I'm working with the Global TB program in WHO in Geneva, and today I have a co-chair.
My name is Seyum Dejene. I work with USAID Uganda as HIV and TB advisor.
So we are going to have a collection of 5 experiences from the field, four experiences from the field who are telling us how they really address this challenge. And then we are going to have at the end a presentation from Greg Fox, who is a researcher who has conducted a systematic review then to collect evidence about what the scientists are telling us about the feasibility effectiveness of different models of care measuring specific treatment outcomes. So my co-chair, Seyum, is going to introduce our first speaker.
Okay, I welcome the first speaker, Dr. Deju Jorane. Dr. Deju has a MD from Addis Ababa University and PhD from University of Bergen in Norway. He has 17 years of clinical and program management experience in TB programs. Currently, he's the director for USAID Challenge TB project that's implemented by MSH in Ethiopia. The topic of his presentation is mixed ambulatory and inpatient treatment model of care, and he's sharing the Ethiopian experience. Dr. Deju, you are welcome.
Okay, thank you, Mr. Chair. I'll be presenting Ethiopia's experience in implementing a mixed ambulatory and inpatient model of care, and by so doing, how the country has contributed to increase in access to MDR-TB treatment in Ethiopia. So actually, I'm presenting on behalf of my colleague from the National TB Program, Dr. Blaine Ayele, who was expected to be here, but she couldn't make it because of visa issues. So, okay, so to give you a bit of background about access to MDR treatment, according to the latest WHO report, we have started to see improvements in access. But when you look at the treatment outcome, we are still low at 52%. 2 years back, it was about 48%. Now it's improving. So in order to further scale up services, we need to also agree on the model of care. And the existing evidence suggests that we have some evidence that treatment is a cost-effective intervention, treatment of MDR-TB. We agree on that. But the main driver or influencer of treatment is the model of care. So we have at least 3 models of care. One is a purely inpatient. We can also think of a completely ambulatory, or we can have a mixed model of inpatient and ambulatory model of care. But when we also talk about the level of service delivery, we can also talk about centralized tertiary level of care and a more decentralized primary and mid-level health of care. So there have been at least 2 arguments. People who advocate for centralized, specialized kind of care, and others are saying that we should provide more decentralized services. So the limitations of a centralized approach from our information is that it limits access, and we have also observed a higher loss to follow-up. The people who go for the centralized approach criticize a more decentralized models of care for fear of compromising quality of care. So what we are presenting is the objective of this presentation to describe how a decentralized mixed model of care can improve access to and quality of care without compromising treatment outcome. We'll see that. And we also want to highlight some of the real challenges and suggest practical solutions based on our field level experience. So a bit of the setting. This is Ethiopia. This is a large country with a population above 90 million. The TB, HIV, and MDR-TB burden, Ethiopia is among the top countries, as the third actually. In 2012, when we started this implementation of a decentralized mixed model of care, there was very limited diagnostic and treatment capacity in Ethiopia. There were only 2 centers located in 2 cities of Ethiopia for a population of 90 million, and patients had to travel at least up to 800 or even 1,000 kilometers to get treatment to Addis Ababa and other cities. So because of that challenge, the Ministry of Health introduced the first ambulatory model in 2012. And so this model is, there are 2 treatment initiating and treatment follow-up centers. So patients are temporarily admitted to the treatment initiating center, and when they get stabilized, they are moved to the treatment follow-up centers where they complete their treatment. So these are the strategies and interventions that we have used to operationalize this strategy. The first one is we started with strengthening the national and regional MDR-TB program coordination capacity by providing trainings, developing guidelines, standard operating procedures, and technical guidance. Then we supported with renovation of limited number of treatment initiation centers. Although this model is not to hospitalize patients, we also had to have the good facility to initiate treatment. Lab capacity was also weak initially, so we built that capacity in order to detect MDR-TB and also follow patients. Providing job aids and patient education materials was another intervention that we provided. And then we assisted the Ministry of Health in monitoring and evaluating the outcome, both to learn from our experience and also to improve the patient outcome. Patients had to come to the treatment initiating center every month for clinical checkup and also to provide food support. We also used the opportunity to do contact investigation. So this is just to show you what a TIC, or treatment initiating center, and the treatment follow-up does. Their primary role in the treatment initiating center is designing the regimen and initiating treatment, inpatient care until the regimen is tolerated, linking the patient to the TFC for direct observation of treatment. Monthly follow-up is also organized and determining outcome. So the outcome is determined at the TIC level. At TFC, the primary role is administration of the medications and observation of treatment, detecting and managing common side effects, or referring if there are serious side effects, and doing contact investigation. These are the roles clearly designated, and people are instructed on how to carry out their duties according to the defined roles. This is to show you some of the materials. We produced dozens of tools and guidelines to support, to standardize the service and how to provide it. This is an example of an MDR-TB center renovation. On the right also you see the cohort wall chart. To improve the treatment follow-up, we used a wall chart similar to the one we use for HIV programs, and our health workers in the centers were able to do and analyze their cohort. Strengthening lab capacity. This is to show you an example of how the expansion in the number of GENEXPERT sites in order to improve the treatment detection from 0 in 2012 to 49, and even more sites are now coming. So So when you come to the results in terms of expansion of services, as you see there, we had only 2 sites providing inpatient model of care, highly specialized. Treatment is provided by specialist medical doctors. And general physicians and nurses had limited role in 2012. So as a result, we had a long list of patients waiting for treatment. So this was a huge problem. So in 2012, when we decentralized this and started, after 4 years, as you see there, we have 48 treatment initiating centers in 4 years. And about 658 centers were capacitated to follow patients. So this is a huge increase, and no patient is on waiting list. Patients don't wait in order to get treatment. This is to show you the number of treatment initiating centers in Ethiopia. We have listed 44 of them here. The first 2, Oromia and Amhara regions, where we were operating through the LIVERPOOL project, has the largest number of MDR-TB treatment centers in the country. So in terms of patient enrollment, at baseline, we were able to do only about 550 presumptive cases were being referred for diagnosis and testing. As you see there, we have a nearly 20-fold increase. In a year, we were doing more than 9,000 presumptive TB case testing and evaluation. So the number of patients enrolled in baseline in 2012, we had only 56 patients. Now we have more than 1,000 patients under care. This is a treatment outcome. So this was one of the points of argument by people who favor centralized, specialized care. And with this decentralized treatment, we were able to achieve a treatment outcome, which is the treatment success rate of the latest cohort we analyzed is 84%, with a cure rate of 70%. So when you compare this with a global average of 52%, most of these patients were probably treated in specialized care. This is, I think, this exceeds most of the global and international and local also targets. But this was implemented with some challenges. It was not easy to expand from 2 sites to 48 sites, especially with a high turnover of trained staff. So we were forced to retrain people in order to cope with the high turnover of staff, not only from health facility to health facility, but even within the health facilities, they keep on changing from one unit to the other. So we have to cope with that training. MDR treatment, there was limited experience. The clinicians were scared of treating MDR-TB patients. They didn't have any information. So we had to do continuous capacity building through continuous medical education programs that we often organized in the TAC center and called all our TAC staff to come and get the information. In terms of collecting results for the MDR-TB patients, that was also a huge challenge. So we had to look for more effective sample transport systems, which we are also working on. So these are some of the challenges we faced during the implementation. So in conclusion, decentralizing MDR-TB services has contributed to improved access to treatment and care without compromising the treatment outcome, with a much better treatment outcome. So for us and in our experience, the mixed model of care was a feasible approach in Ethiopia. And we think this could be so in other countries with similar challenges. But this was not achieved without strong technical support and close collaboration with an NTP. This was a critical element. We had to invest both technically, materially, and financial support was invested through USAID. So that level of support should be maintained in order to keep this good treatment outcome in place. We are now working on introduction of new drugs and short regimens, which we think can also contribute to significant improvement in treatment outcomes. But we can also follow the same model. So our worry now is we are starting to centralize the treatment of treatment with the new drugs. I think we should follow the same approach. We followed the same approach for HIV, it worked. We followed for the MDR-TB, and with any new drug or any new intervention, I think we should follow the same approach. Nothing is totally new. So this is our recommendation. I would like to thank our colleagues from the regional health bureaus and treatment sites for their contribution to this, and of course the NTP. During the guideline development, TB Care 1 and Challenge TB also on the latest part of the project had some contribution, so I would like to colleagues from KNCB for their contribution. Thank you.
Thank you, Dr. Dagu, for excellent presentation and also for keeping the time. You are on the spot. So we'll keep the question to the end. So you just take a seat in the front row. I will invite the second presenter. Our second presenter is Dr. Raymond Bayurhanga. He's Chief of Party for the USAID track TB project in Uganda, implemented by MSH. Previously, he served as the Executive Director for the AIDS Information Center in Uganda. It's a local NGO. So his topic is achieving rapid scale-up of MDR-TB treatment using decentralized mixed model of patient care in Uganda. So the topic is similar to in Ethiopia, so you can see and compare the difference and similarities in these two presentations. So go ahead.
Thank you very much, Chair and the Co-Chair. Colleagues, I'm presenting, as the Chair said, what we have achieved in terms of the rapid scale-up for MDR-TB patient treatment in Uganda using the mixed model for MDR-TB treatment. And this has been in great collaboration with the NTLP, the Ministry of Health, and Stavia in particular, who is our MDR-TB coordinator within the NTLP. As a quick introduction, Uganda is one of the high TB HIV burden countries as by the WHO guideline, by WHO classification. We have an estimated population of about 35 million, an annual TB case notification of 46,000, treatment success rate and cure rate for the TB patients of 80 and 55% respectively. MDR-TB prevalence shows that we have about 1.4% for new patients and 12.1% of the previously treated TB patients. In 2012, when Track TB started providing or came into providing MDR-TB services, at the time we had limited access to MDR-TB diagnostics and treatment services. We had a very long waiting list of more than 300 MDR-TB patients. There was already some other institutions that were providing MDR-TB on a research basis. There was lack of technical capacity for program management of multi-drug resistant TB. Was lack of MDR-TB diagnosis capacity. I think that time in 2012 we had about, if there were many, there were less than 10 GENEXPERT machines. Inadequate MDR-TB patient space, care space at the hospitals. There was, I think, 1, 2 or 3 patient initiation sites. Lack of funding for TB logistics and patient support, and then lack of health management information system for MDR-TB services. As part of the interventions that Track TB, with support from USAID, was able to do, broadly, we built capacity by having a national PMDT technical working group. We had regional multidisciplinary teams at selected hospitals that were initiating MDR-TB. We introduced the mixed model for care in terms of what my colleague Degu has just said. For some time, hospitalization, inpatient, and then later ambulatory clinic-based care at the follow-up facilities. We supported through USAID renovation of about 13 MDR-TB sites with our colleagues from URC in terms of renovating MDR-TB sites. Decentralized MDR-TB treatment services, and we expanded the GENEXPERT technology from about less than 10 to now more than 112 GENEXPERT machines in the country. That is one of the renovated sites I don't have it. On this side, the site is under renovation, and some of the people we see there are actually hospital administrators. This shows ownership of the facility, and on the other side, it is a fully renovated health MDR-TB ward for MDR-TB patients. Specific interventions. We provided there was home assessments for MDR-TB patients and social support for patients, looking at enablers like transport refund for the TB patients from their homes to the nearby facilities and to the initiation sites on a monthly basis. We provided capacity building and supportive supervision for peripheral health facilities for the DOT team. Patients received daily DOT at peripheral health facilities and attended monthly review clinics at treatment initiation sites. That's the map of Uganda, and that's where we are in Africa. And those are the number of treatment sites that we supported to scale up MDR-TB, right from 1 or 2 in Kampala and just in northeastern Uganda. We have now we have about 15 MDR-TB treatment initiation sites in Uganda. As a result of the rapid scale-up from 2012 to 2015, this graph practically shows us that at the time we started, we had, in 2010, we had more of the patients at the treatment sites, initiation sites. But as the graph continues up to 2015, the red bar practically shows those patients that have been treated initially at the facility but are now receiving their treatment in the decentralized process in the follow-up facilities. And you can see that every year we are decreasing on the number of patients at initiation site. This is to help improve care for these MDR-TB patients. Since 2012, this is 2016, we have had one national cohort review, and interim results for the 2013 show a great improvement in terms of treatment outcomes. And in final treatment outcomes show that actually we had a 60% cure rate. And from our results, we see that we still report a high mortality rate, but we think that this is attributed to the late start for many of the MDR-TB patients that started in 2013. But there are great results in terms of our treatment success rate, which is at 74%, and the rest of the results, including loss to follow-up, which is 7%. This is just among the 120 patients who completed treatment after 24 months. Despite all the implementation, we still have some challenges which I believe we're improving on and addressing. Like our colleagues from Ethiopia, we have a shortage of healthcare providers and a high turnover of trained healthcare workers from a number of these initiation sites, which are in rural settings. So there's a lot that we need to do to motivate our staff to remain. A weak social support mechanism for patients. Many of these patients are poor and they need a lot of social support. Inadequate supply of TB logistics. We're grateful to the Global Fund that has been able to provide a lot of these second-line drugs and other logistics. Suboptimal utilization of the GENEXPERT testing by MDR-TB for case detection. I think this is something that actually we are really working on as a country, and a lot is now being implemented in terms of increasing utilization of GENEXPERT testing, including a recent guideline that all our presumptive TB cases should all get GENEXPERT testing. We had a challenge of inadequate admission facilities, and as a result, as I said above, that we have been able to renovate 15 sites, and we have adequate admission facilities. I would like to conclude by acknowledging our Ministry of Health, the National TB and Leprosy Program, for the good leadership they have shown, the Global Fund, WHO, PEPFAR, and USAID Uganda, Management Sciences for Health, our technical support that we've been getting regularly from the University of California, San Francisco, implementing partners, healthcare workers, patients, and their families. I thank you very much.
Thank you very much, Doctor. So we are going to take questions from the floor at the end of the session, because we need to be very timely with the end of our symposium. There will be another one coming. So our next speaker is Dr. Norbert Jaka. Dr. Jaka is a medical doctor. He is the person responsible for MDR-TB management in the Department of Health in South Africa, which is another country that has facing this major challenge, how to really mobilize a response that allows quick enrollment on treatment of a big number of patients with MDR-TB. And they have been facing this kind of artificial dilemma, I would say, about ambulatory or hospitalized model of care. So, floor is yours.
Thank you, Chair. Colleagues, I'll take you through a short presentation on the integrated home-based treatment for MDR-TB in South Africa. As you've already heard, we really have a very high burden. We high burden for TB, for HIV, and for MDR-TB. I think the three categories, we don't like it. It's a lot of work, a lot of responsibility. We really take that very serious. I'd like to say, start by saying that I've got no conflict of interest as I speak to you. I've not been paid by anybody to talk about my own work. I just feel honored to really share with you what we work on every day. Decentralized management of MDR-TB has been quite a controversial topic at some point. Hospitalization was just what we did, and at some point we started to discuss about it. It was very controversial, but today I'm very happy that it's become standard of practice. That's very good. So I'll take you through a short background. I'll remind us the reasons why we had to go this route, give a brief explanation of the model. I think most of what I was going to say have been covered, so I will not really spend a lot of time on this. I'll look at our performance, program performance after this exercise of decentralization. What have we learned, and how do we want to move forward by concluding? Now, this is just to give you an idea of what South Africa is. As you can see, a country with 52 million people, 9 provinces, 53 districts. We got more than 3,000 beds for MDR-TB treatment, but it's not enough for the number of patients that we have. Now, the other feature of our program is the expert. We've achieved the universal coverage in terms of expert. So the green dots that you see there, those are experts, GENEXPERT distributed in the country. What we did was to place them at all the sites that previously diagnosed MDR-TB, tuberculosis using microscopy. So we have on where you see that is there a laser here? Oh, sorry. Where you see the no green points there, the border with Namibia, there aren't really a lot of that. There aren't people basically living in that area, so that's why you see the ant green point. Now, in terms of the program itself as well, we've also tried to scale up ototoxicity management. We deployed 126 high-frequency portable devices because it's very important to have that. But then because we do not have capacity to interpret results everywhere, we use telemedicine as a means to get audiograms interpreted so that clinicians are able to follow their patients. Now, this is where we are as of today. You will see in the global TB report that we have around 78, 82% success rate. But what is important here to note is that the case notification for tuberculosis has been dropping over the last few years, while the MDR-TB is increasing. And if you look at the 2013 cohort, our treatment success rate has been reported as 49%, and I think this was updated in the report, it's probably 48. But these 11,000 we're talking about here, this 12% of the global cohort. You would recall WHO reported that in that year, 97,000 individuals were initiated on treatment globally. So 12% of the 2013 cohort come from the one TB program of South Africa. I think that by itself tells you what we're really dealing with because it's really just a lot of patients for one single program. In terms of XDR-TB, of note is the highest mortality. You can see we used to report 44, 50. It's dropping a little bit when we do cumulative data. We talk 38% among our XDR, so, but that's very high. Again, I mean, it's like losing half your XDR. So that's basically the program we're talking about here. This is really the TB program. The patients are seen everywhere. Now, why did we come to this idea? We decided to go this route because our patients will wait for a month or more to start treatment, and we now know that is not right. I mean, people who are sick, who are infectious, who are not on treatment in the community, spread the disease. That's all they do. So we didn't have enough bed to admit everybody. We had a lot of patients to start treatment, and we kept them. We wanted to do a good job. We did isolation, but it was difficult to find beds for everybody. Some of the patients would travel a long distance, 2-3 days for admission, and you would know when you have to be admitted, you lose your job, you know, socially it's not correct. Risk of transmission in hospitals is also a factor, but overall our outcomes were just not very good. When a colleague from Ethiopia was presenting treatment outcomes, I was like, okay, if you think 52% success rate is not good enough, you know, you need to see what's happening elsewhere. But I think when you have, you know, a program, you have work to do, you don't have to look elsewhere, but definitely our outcomes at that stage were like, what, 30% success rate or so, very, very low. Now, we then decided to embark on a journey that took us 27 months. 27 months are enough, you know, if you initiate people on MDR treatment today, 27 months down the line, you should be able to get their outcomes. You get your entire outcome report, but this for us was really time for discussion to prepare in terms of the workshops, the meetings, and up until the policy was approved. I think this is familiar, you're all familiar with these processes. Most of the time when decisions are taken, the activists want results straight away, but to come to such important decisions, oftentimes they time spent in the boardroom could just be enough to really start and do the job and cure people. I just thought it was important to share this. But we really received WHO support on this one, as we're able to deliver a good product. And this is what happened afterwards. Because before, we only had decentralized units, a few of them in the provinces, some in most of our provinces. But with the policy framework, we're able to have decentralized sites in the districts and more sites, and even be able to go out and see patients where they live if they could not come to our facilities. Yeah. So this is what we decided upon. We said we needed to train our people, our healthcare workers properly, and provide access to audiometry, drugs, and laboratory. These are key components. If you don't have this, it's very difficult to run your services. Of course, your data is critical. Data services are very important. If you don't know what you're dealing with, you can't take effective decisions. So this is what happened. This is just to give you an idea. When you say home-based trade, because our decentralization, it's really like all the models where you have, we're strengthening hospital services, small clinics, but be able to see patients in their homes. And seeing patients at home, this is what it means. You go to places like those in KwaZulu-Natal, or you see in the homes, and a lot of these patients' homes, you can see they're not necessarily like your standard homes in Johannesburg or Pretoria. So this is what we've been able to do, and it's really very helpful, because then you get to know your patients very well. You know them, you can handle them holistically. Now, the other thing I can say is that since we decentralized our care, we found good results, but also our other colleagues, our partners who supported us from the beginning have done some, objective external analysis, and I found that indeed we have activities which are really more effective. We can do more with our MDR-TB rather than keep them at home, wait for a bed in a month or two. We feel that it's much better now. Decentralized care is more effective. In fact, you find that treatment success rates at smaller sites are better than bigger sites, and you also have less problems with nosocomial infections and all that. Is it cost effective? Because you want to know, you can't just, some people say when you decentralize care, it gets very expensive, it's very dangerous. Other colleagues have looked at cost effectiveness analysis just to check whether we have a service that really is giving us value for money. Does it justify further investment? Do we carry on? So there's been extensive work around that. Our own reports have found the same thing. We feel that we're moving in the right direction. We're giving a better treatment. In terms of success rate, I must admit there's not been much improvement, but it depends on what you call improvement. If 2010 cohort says 40% success rate now, quarter one 2014 we reached 53%. We're going above 50% for the first time. To us, this is progress. It's really worth commending, because you're looking at a cohort here of 3,000. Just one quarter is 3,000. And these are not patients treated in academic sites. In fact, our academic sites don't treat MDR-TB. These are state facilities, small hospital clinics all over. So they're really treated within the various facilities, the clinics and all these others. When you look at XDR-TB, 31% success rate, it looks quite good. We used to be way below 10. Now it's 31%. In fact, analysis of some of our facilities which have used a lot of new drugs, new and repurposed drugs, show that in some instances you get better outcomes for XDR than MDR-TB. Yes, we do have, when you do quarterly analysis of facilities that make effective use of new drugs, what we see is really decreased mortality among your XDR, MDR, and better outcomes, 60–70% outcomes, success rate in XDR, because in MDR we give conventional regimen, but with XDR, pre-XDR, we prioritize new drugs, and we see better, outcomes in those areas. So this is a space to watch, and we thought that it's important to do. We've been able to scale up new drugs because of the existing decentralization, decentralized care. Because if you decentralize care, you're decentralizing people and the means, the resources. So any resource that you get could use the same channels that you have. Of course, you also need a strong health system because TB cannot sit by itself. You have TB services within the general health system. In terms of facilities, we used to have 17 treating facilities. Now we moved to 648. I showed you earlier on that you got 4,700 clinics, primary health clinics and health facilities. So the dream is really to get it, to get treatment everywhere. But you got to start somewhere and move progressively. There are nurses that we treat. We've got 10 sites, which are where MDR is initiated by nurse practitioners, and 155 teams that go out to provide treatment at patient homes. And of course, there have been huge savings. When you cut down on admissions and physicians' time and all those things, the care become more available and you get better treatment outcomes. Now, what have we learned really? You need health professionals to buy in. If you get your health professionals to buy into this type of initiative and you plan properly, you will not have 2 years of discussions. If we are to do similar work, we won't take 27 months of preparation. We could probably take less because if you really target people who have to do it, you get their buy-in quicker, But it's not a one-size-fits-all. You've seen those homes. There are different types of homes. Now that's where the challenges are. Because even within the provinces and the districts, you find these ones have a lot of doctors. The other districts, there's no doctor who want to work there. I don't know why sometimes medical practitioners become selective, So it's a problem. So you got to plan around your resources, around the number of nurses, nurse practitioners, physicians, hospitals, and clinics. But the underlying, the key principles have got to be the same. And that's really what is difficult. How do you use the same key principles but for 3 different models? And you've got to make sure your hospitals are getting better, as well as your community care, including home-based care. But dedicated funding is you see, I put finances as a last bullet. I don't think is the most important thing. With clear planning, you will know exactly what you need. If you don't plan properly, you might get a lot of money and even misuse. But what I've seen is that with building renovations, normally this one becomes problematic because the funders don't want to touch. And most of the time, government also has other priorities. A lot of governments prefer to build operating theaters and casualties, so it becomes very, very difficult. Now, what I can say in conclusion is that by decentralizing care, and especially the home-based activities, we've increased access to care, including access to new agents, because that's really what we've done. And it reduces time to MDR-TB treatment. We used to take a very long time, 2-3 months, but with decentralization and expert, we do take a reasonably short period of time before we initiate, and we hope that this is reducing transmission. And this has also improved continuity of care, clinical outcomes. It is cost effective, and most importantly, this is patient-centered. So this is my message, and I really thank you for listening. These are my colleagues. We had a visit in one of our provinces, a home visit to administer MDR-TB treatment. And I thought maybe I should present this evidence as well as our policy document that guide us in doing this. Thank you so much.
Thank you, Norbert. We'll wait for the question to the end. The following presentation was supposed to be from Peru to capture the Latin American experience. However, the National TB Program Manager was not able to travel and was not able to find also a replacement presenter. Swaziland was flexible enough to chip in and make presentation of their experience. So with that note, I'm inviting Dr. Welile Secondes. She is the National TB Control Program Technical Advisor and a Research Coordinator. Her topic is challenging MDR and XDR-TB through decentralized mixed model in Swaziland. You are welcome.
Thank you very much, Chair and Co-Chair, and thank you for the opportunity to share the Swaziland experience on strengthening of PMDT. I'm doing so on behalf of the PMDT unit within the NTCP, which is led by Dr. Deborah Vambe, who couldn't join us this week. So I'll be sharing some of the experiences in Swaziland that we've been encountering in terms of decentralized models of care for MDR and XDR-TB. I have no conflicts of interest to declare. So Swaziland is considered a high TB/HIV burden country, and as of the latest global TB reports, we have a case detection rate of about 60%. We are progressively improving in terms of our treatment success rates, but the last drug resistance survey, which was conducted in 2010, revealed MDR-TB rates of 8% amongst new cases and 34% amongst previously treated cases. And this is triple the regional average for surrounding countries, South Africa, Mozambique, Zimbabwe, Lesotho. So we are really considered within the region to be a high DRTB setting. And unfortunately, a lot of our patients, close to 100% of our XDR-TB patients and 80% of our MDR-TB patients have TB/HIV co-infection as well. And we have estimated that approximately 10% of our MDR-TB patients will eventually develop, graduate, or be diagnosed with extremely drug-resistant TB. So as with most countries, there's mixed methods in terms of the models of care or mixed models of care that are provided for DRTB services. We do have ambulatory care, which is a combination of clinic-based as well as a community-based model, and we maintain hospitalization for those patients who are critically ill or who require additional supports, for example, have adherence issues, psychosocial issues, or will encounter problems with their socioeconomic status. In addition to providing a clinic-based and community-based model, we also have what we call our regional MDR-TB clinical teams, which consist of an MDR-TB doctor, MDR-TB nurse, a social worker, and an adherence counselor, as well as, in most cases, a linkage with an audiologist who are able to support some of the facilities at regional level. In 2011, 2012, the country opened our National TB Reference Hospital, which is mainly reserved for complicated cases. It's in the center of the country. So it serves the entire, it's a national referral hospital for DRTB, complicated DRTB patients. However, services have been decentralized to each of the regions, each of the 4 regions, Hoho, Manzini, Shiselweni, Lubombo, and through large amounts of MSF support, we've been able to have community-based services in some of the regions as well. So I've already mentioned that we have our regional MDR-TB clinical teams. We also have our community outreach teams who conduct home assessments for infection prevention control assessments, determine whether it would be safe for the family if the patient is allowed to stay at home. They do psychosocial assessments, and they also do contact tracing and follow-up for the patient's contacts. And this has also helped in terms of strengthening the community care and ensuring that the community members and family members are comfortable and at ease with having patients, MDR-TB patients in the midst. So it's gone a long way towards community engagement as well. I'm going to focus mainly on the Shiselweni region. The Shiselweni region, which is the region in which we have a very good model when it comes to community care. So this graph is just to show you that over the years, this only goes up until 2013, but over the years in this particular region, which is implementing a fully community-based approach, as well as some patients who still require clinic services or clinical-based care, over the years, over the last 10 years, we've been seeing an increased proportion of patients who opt for community-based care. And this has also become evident when we review our TB treatment outcomes for the 2009-2013 cohorts. Those patients who are taken care of closer to their most comfortable environments without inconveniencing them for accessing care have been shown to have better treatment outcomes. And this goes hand in hand with psychosocial support, an enhanced psychosocial support package, as well as an intense patients follow-up system, which involves community treatment supporters. And in some cases, patients will identify a family member that they are comfortable with sharing their status with and who is comfortable enough to provide DOT at family level. So our treatment outcomes for those patients within the Shiselweni region who are receiving clinic or clinic-based medical attention is at 68%. Those the mixed methods or mixed models at 67%. And those who are being taken care of at home or in the community have the highest treatment success rates of 76% currently. So this, just to re-emphasize the previous slide, that when we compare within this very same region, it's almost as if we have an operational research study taking place by design. Some patients ask for community care, others opt to be seen within the clinic. We've been able to compare between the two groups of patients to compare their treatment outcomes in terms of their success rates, but also their mortality rates. So those patients who are inconvenienced enough to have to access care at a facility level we've also seen a reporting of a higher mortality rate amongst that group, as well as very similar defaulter rates as well. So when the country was deciding whether to scale up the community-based approach to all the other regions, we engaged through MSF support as well as with CHA, we conducted a cost-effectiveness analysis to see whether the additional cost was significant enough to be a barrier for scaling up of community-based care, and there were very minimal differences between the cost for community care and clinic care. And we found that in our setting, the cost really comes in patients having more favorable outcomes when treated closer to home or when treated in their environments that they're most comfortable with less barriers for accessing services. So there are similar costs in both care models, and they're similar because of the additional home visits required in the clinic-based care model. So for the other regions, they also use, the other 3 regions in the country, they also use a hospitalization method for those critical cases. Patients access the clinic for daily injections. We have community treatment supporters who provide directly observed therapy for those patients on their oral medication, and then they have monthly visits to DRTB facilities. What we have found to be very critical, we have 2 regions in whom we are able to provide a comprehensive patient support package, which includes food packages and transportation cost reimbursements. And in those 2 regions, in Manzini and Shiseleni, we have seen that patients have a better adherence to care, a better treatment, and more favorable outcomes. And unfortunately, currently there's only 2 regions in the country who are able to do this through MSF support, and we're using the natural randomization of these 2 regions as a means of advocating for this to be scaled up to all patients in the country at national level to include the other 2 regions as well. So that all 4 regions are able to provide DRTB patients with food packages and transportation reimbursements through the Ministry of Health coffers. It's a process, it's something that we are still in discussion with the Ministry of Health, with Global Fund support as well, and we hope to be able to implement this as of mid next year. What we are seeing though is that patients in the other 2 regions will rather default where they are currently being seen or move to the 2 regions that are able to provide patient support packages. And that is also resulting in losses to follow up. So in terms of the National TB Hospital and the Pietersburg Hospital currently, of the 6 to 8 facilities, the only 2 that are unable to provide patient support packages to patients. And as you can see, when comparing treatment outcomes at facility level between those facilities that are able to provide a comprehensive patient care support, treatment outcomes are obviously a lot better, as well as they are less likely to end up with unfavorable treatment outcomes in terms of death, defaulting, transfer outs, and loss to follow up. So in conclusion, treatment support packages are important in ensuring that patients are able to adhere to their treatments. It's really critical for us to allow for an environment that is not inconveniencing a patient in accessing their care. Community-based care and support packages can overcome some of the barriers for rural communities, especially when you look at the long travel distances that patients have to undertake in order to access care, especially for those on the intensive care, in the intensive phase who require daily injections. A constant barriers, unfavorable socioeconomic circumstances, and we're still finding this to be a challenge as we are looking at rolling out our new drugs like bedaquiline and delaminate. We're still only able to do it within the 4 facilities in the country, and these are some of the barriers to further decentralization. So what we have found in terms of our lessons learned, key elements and steps to choosing the care model, 1 is advocacy and political will and commitment, but also to understand the patients and the community in which the patient lives, and to ensure that there's sufficient community engagement and regular contact sessions with the community who can oftentimes reject patients, and that also will encourage unfavorable outcomes in some of our patients. We found it really critical to ensure a comprehensive patient support package is made available in terms of reimbursements for transportation costs for accessing care and food supports, not just for the patients, but for the family, as well as incentivizing the treatment supporters at community level. So we have, each of our patients is assigned a community treatment supporter who is incentivized to ensure that they do oversee treatments, management, or taking of medication on a daily basis for each of their patients they are assigned to. Thank you.
Thank you very much, Dr. Welile, because this is really a very thorough and well described analysis of the process that Swaziland has passed through. But what we have seen so far are just some experiences from the field, but we also need to understand what will be the picture when you conduct a systematic review and analysis that with stringent criteria can select the best of the evidence that can inform policy making. I'm very much pleased to invite our next speaker, Dr. Greg Fox. Greg is now working at the University of Sydney in epidemiology and TB analysis of data over a variety of regions in the world. So he has been contracted by WHO to conduct a systematic review to update the guidance on models of care that has been made since 2010, which is to use preferably an ambulatory model of care. So Greg, floor is yours.
Thanks kindly for the opportunity to present the work that I've done with Dr. Jennifer Ho and Anthony Byrne from Sydney University on behalf of WHO. I have no conflicts of interest to declare. As we've heard today, I think very clearly and effectively explained, there are significant disadvantages with traditional models of care. So not only is the cost a factor, but also, importantly, concerns about patient adherence to therapy and the ability to avoid the result of nosocomial transmission, potentially exacerbating MDR-TB transmission in the community and prolonged hospital admissions. So in the context of this, the policy question really is, do we have evidence to go and justify a decentralised model of care? And can we take the data from various studies that have been performed and draw any conclusions? And so the research question that we were asked to review was, is decentralised treatment and care for MDR-TB patients more or less likely to lead to the following outcomes compared to treatment provided solely by specialised drug-resistant tuberculosis centres? And the outcomes were improved treatment outcomes overall, treatment adherence, adverse drug reactions, acquired drug resistance, and patient and health services costs. And as you'll see in the review, we're unable to answer all of these questions, but I will be presenting today the data we could obtain, which is in relation to treatment outcomes, some data around treatment adherence and adverse reactions, and then about health services costs. So the population that we used to define the inclusion of our studies were individuals treated with multi-drug resistant tuberculosis. And essentially, we contrasted centralised care to decentralised care. Now, as we've seen in the presentations today, in fact, there's a great deal of heterogeneity in the understanding of decentralised care. And so we chose to define it as care that was conducted in the local community in which the patient resides. And we chose to be inclusive of both community health centre, clinic or religious or other community venues, as well as home-based care. And we recognised that many decentralised programs offer initial inpatient treatment, particularly during the period prior to treatment response. And so we allowed for a brief period of initial hospitalisation. Now, the decentralised care could be delivered by a range of care providers, whether that be trained volunteers, community nurses, or non-specialised doctors. The critical distinction being that this was not a tertiary level care service provided by specialised doctors, but provided by a more community-based level of health worker. In contrast, the centralised care were specialised hospitals, and they were usually sites where specialised nurses or doctors were available with experience in treating MDR-TB as their primary activity, and it included centralised outpatient clinics. That is, clinics where patients might come daily to receive DOT, but at a centralised facility. And we defined the treatment outcomes according to WHO definitions. So we applied essentially the grade approach and used the standard methodology recommended by PRISMA to conduct the review. So we examined multiple databases, and I can show you at the end, if you're interested, the search terms we used to systematically review the literature and to identify studies that met these inclusion criteria. You can see here a consort diagram of the eligible papers that we reviewed. So of the 1,818 records identified through databases, as well as an additional 6 that were identified through hand searching of grade literature, we reached 1,824 titles and abstracts which we examined, and that led us to have 41 full texts and then a final 8 studies that were included in the review. Of those studies, there were 6 which were in fact controlled studies evaluating the outcomes of community-based versus centralised care, and 2 modelling studies. In addition, we also just put aside some uncontrolled studies as well, because in addition to those, there were 16 studies where there was no control group shown. In fact, there have been around about 10 systematic reviews published over the past 10 years or so around this issue. But in all of the cases, the inclusion criteria didn't require that the patients who were receiving community care and receiving centralised care be taken from the same study. And so it's a bit like comparing apples and oranges. And so we chose for our main analysis only to choose studies where the same setting, the same location was where both the community and the centralised treatment were conducted. Now this is obviously a very busy slide, but just summarises some data about the included studies. And I just make a couple of points as an overview in relation to these studies. So first of all, most of the studies were conducted after the year 2000, and all but one, Narita, were conducted in resource-limited settings. But in fact, there was a substantial variability in some of the epidemiological characteristics. So that is, HIV prevalence varied from 0.9% up to 70 or up to 81%. The timing of the intervention, that is the community-based care and the control group, varied. So in some cases they were concurrent treatment, so you had the community care and centralised care being conducted at the same time. In other studies, such as Chan in Taiwan or Cox in South Africa, you had essentially a historical cohort being used as the control, and then a new intervention, the community-based care, led to the second arm, the intervention arm. And that's significant, as I'll talk about in a minute, because of issues of bias around comparability in settings where you have sequential recruitment. Now, there are 16 uncontrolled studies, which we won't go through in detail today, that give additional information, but unfortunately it's difficult to go and compare these uncontrolled studies with one another because there's huge variability in the patient populations and other confounding factors that might influence an attempt to look at an effect. So I'm going to present the patient important outcomes now. So first of all, treatment success. So you can see here in the blue the controlled studies. And so in the decentralised model that we looked at, treatment success occurred in 67.3% of patients with a fairly high I-squared value. I-squared is an indication of heterogeneity, where 0% is no heterogeneity and 100% is very significant heterogeneity. So you can see that indicates there's a lot of variability in the estimates. In contrast, centralised care had a lower proportion of treatment success, 61%. And you can see that these comparisons were quite different to the decentralised studies where there was no control group at 76.1%, justifying our decision not to try and pool the decentralised without a control group with the others. And so when you go and do a forest plot, you can see here that the effect estimate overall on four of these studies lies onto the right, which indicates an effective treatment resulting in greater treatment success. And so therefore the relative risk was 1.13 with confidence limits between 1.01 and 1.27. So this tells us that there was an association between the decentralised model and increased treatment success. You can see Narita at the bottom lies on the other side. This was a very different context. This was in the United States, mostly in the 1990s, in a healthcare setting where the sickest patients tended to be the ones who were in the community, and so they got less effective care. And so perhaps for various reasons that's a different context and explains the variability to some extent. Now in contrast, death, you can see it was very comparable between the decentralised and centralised models. Again, looking at the blue controlled studies, you can see 17.8% versus 18.6%. And so therefore, the relative risk confidence limits crossed the null. So there was no difference in death in the studies that we could elicit. In contrast, similarly rather, treatment failure also was very similar between the two, with relative risk of failure being 1.07, clearly with the confidence limits crossing the null. But interestingly, when we look at loss to follow-up, it's almost the inverse to treatment success, which is logical, I think. That is, in the decentralised care model, you had only 11.9% of individuals being lost to follow-up. In contrast, with centralised care models, there was 18%. And so that resulted in certainly a trend with 0.66 relative risk of loss to follow-up. And so that's consistent really with what we've heard today from our earlier presentations. That is, when you have people having to travel long distances, there are disadvantages, one of which is loss to follow-up. And so that suggests from our data that probably most of the difference is seen due to the loss to follow-up in relation to the treatment outcomes. Now, so that was the overall effect. Adverse events are very difficult to evaluate because the quality of the data is quite limited, and so there were no controlled studies which compared the reporting of adverse events for those in centralised and decentralised models. But when we pooled all of the studies with no control, we were able to find that 86.3% of people in one of the 9 studies where this was reported had adverse events, 22.2% had severe adverse events in the 3 studies where this was reported, and 7.4% had adverse events requiring discontinuation of treatment in the 8 studies where this data was available. So certainly this identifies the issue that adverse events are important both in centralised and decentralised care. Unfortunately, it doesn't answer the question as to which setting manages these better and whether there's harmful effects as a result of adverse events being managed in a more decentralised setting. We'd need further studies to evaluate this. As far as costs, again, there's limited data. There were 3 studies which used, in most cases, in 2 of the 3 cases, essentially a theoretical estimate of what the cost for treatment would be in the 2 settings. And so in Musa and in Sernanavik, you could see that the decentralised care apparently was cheaper than the centralised care, about 50% of the cost to 75%. But Kirschberger, the paper that we heard presented just before this presentation, found approximately equivalent costs for the home-based care and the clinic-based care. And this, I think, reflects substantial variability in the way that decentralised care is delivered. But certainly there's no indication from the data here that the costs of decentralised care are higher. At least they look equivalent. So you can see already from the data as I've been going that there are some substantial limitations in the data that we have available. Most importantly, many of the outcomes we're interested in were not evaluated, including an ability to compare adverse events and to be able to look at costs in a larger number of studies. Pooled estimates were only based on a small number of studies, and so there was also substantial heterogeneity, and this means that we have to be cautious about the findings. And really, I think these data do certainly suggest that there may be a benefit, but I think if we want to go and answer this question definitively, better controlled studies are needed. One of the major methodological limitations that I alluded to earlier is that there is huge potential for confounding. If you include studies, for example, which occurred in the past, say in an initial time period as the control, and then you start an intervention and then you make that the intervention, then there's all sorts of temporal factors that might change treatment outcomes, including the change in the treatment regimens available, the experience of the staff, or the resources invested in a program. And so therefore, having a control group which is properly matched is very important. So in conclusion, I think randomised studies would certainly be desirable, and it's very important that programs are looking very much at the costs of their own programs in their own context before drawing conclusions about which is more cost effective. But having said that, there does appear to be evidence from our summary data that there is a reduced loss to follow-up and an increased treatment success with community-based care. Thank you.
Thank you, Greg. Thank you very much. Now, floor is open for 16 minutes of questions and answers. If you can help us with a mobile mic. Are you totally convinced with the evidence? No questions, no comments? Yes, please. Now there are 2, 3.
I can project, it's fine.
Yeah, sorry.
Hi, Zoe Demko from the U.S., presenter from South Africa.
Yeah, Norbert.
Hi, very interesting. I was curious as to what you think is happening with the really reduced case reporting numbers. If I remember that slide correctly, MDR was way up, but the overall number was way down. And I was wondering just what you think might be contributing to that. There you are.
The decrease in number of case notification for tuberculosis, I think there are fewer cases that this is going down. I think most parts of Africa have also reported that the numbers are going down. I personally believe that is what is happening. And my reasoning is that in the past we used microscopy. Microscopy has a sensitivity of around 50%, sometimes as low as 37%. I mean, we're talking patients here. The cohorts as presenting have around 73% HIV MDR-TB co-infection, which means your TB diagnostic becomes very difficult. You must throw away your classic textbook. There's nothing like some of those upper lobe cavitation, whatever, lesion we learned in medical school. Very difficult. You have a lot of features which are different. So it's very difficult to diagnose with microscopy. When you change, you put expert in all your microscopy sites, and you assume that, I mean, it's been, we all know sensitivity for expert is double or maybe very high compared to microscopy, and you still see less cases. It's not about poor data collection. It's really data that is coming down because the same data systems that collected cases during microscopy time is what is being used for expert. You know, so they've been. But why is it difficult to say?
I would like you to.
I finish now.
There are a queue
Yeah,
now
I'll finish. I think this is important. Why is it difficult to really give a proof that numbers are coming down? It's because the laboratory systems and the treating facilities do not have unique identifiers. So that's really the challenge, why you don't have like a final report to say numbers are coming down, and we're working towards that. Thank you.
Thank you, Norbert. Darcy.
Okay, maybe you can stay up there because I have another question. I'm Darcy Richardson from the US. I want to thank all the presenters for those very interesting talks. And for you, Dr. Njeka, I just wanted to ask you, in terms of when you say there were lots of savings, it was a lot of savings and good cost effectiveness for the work that you did. What did you actually include when you were thinking about costs? So what was the universe of those costs that you looked at when you said this was more cost-effective approach? And then for all of the speakers, I think one of the things we talk about a lot and we hear about a lot as a barrier to treatment adherence is stigma. And I didn't hear anybody talk about that directly. We talk a lot about patient support packages as nutrition and financial support, but what support is being provided to patients to deal with issues around stigma for all the presenters? Thank you.
All right. Yeah, in terms of cost, I refer to hospitalization costs as well as patient costs, because patients also spend a lot of their own money to travel around. Now, in terms of nutritional support and social support, I didn't mention because in South Africa we have our social agencies provide social care in a form of grant or food parcels to people who are needy, not just MDR-TB, but all the people who are needy. So it's part of the general health system, not a dedicated MDR-TB intervention.
Thank you, Norbert. How about the other speakers to take the question from Darcy? Would you mind to come to the podium and give a quick, brief answer?
Thank you very much for that question. I think for Uganda, stigma has been tackled in two ways. One is that whereas we provide a lot of support to the MDR-TB patients, we piggyback actually on our HIV/AIDS structures that we have. And for many of the facilities, initiation facilities that we have, we also have counselors that really work with these patients. But also that we have introduced a new mechanism whereby we're having expert MDR-TB cured patients that are really working very closely with these new MDR-TB patients that are being diagnosed. And in that way, they keep motivating them, providing social and reducing a lot of stigma among them. Thank you.
Thank you.
So thank you for asking the question on the stigma. This is it's a very common problem, by the way, and we thought, I come from HIV program. I spent many years working with the ART program, and the strongest, the best intervention we had to reduce the stigma among HIV patients was to bring ART, that HIV is treatable, and we can make it a chronic disease which can be manageable. So, but when I went to some of the health centers and started looking at the TB program, this idea was not well received there, and people didn't think that stigma was a huge problem in the TB program. So what we have started is now we are also starting to follow the same model from ART program, that MDR-TB is treatable, and it's curable, in fact. It's not just treatable. So that is contributing to reducing the stigma. And also there has not been any structured counseling and support for the MDR-TB and the TB program overall, and MDR-TB program specifically. So we are also have developed guides and tools to provide structured support for stigma and discrimination, and I think that will show some results in the coming years. Thank you.
Thank you. May I ask Greg, although stigma interventions were not part of the outcomes in the systematic review, did you come across in the review of stigma appearing in some of the papers review as a variable that was analyzed or that was measured in one way or another?
I didn't come across that. Most of the papers that we included that were non-randomized essentially were measuring treatment outcomes. And I think the points that have been made, I think, highlight that it's very important to be able to do further research to be able to evaluate this, and I would certainly support that. There's a big gap in the literature around the effect, because obviously delivering care in the community can highlight the presence of disease in a way that centralized care may not.
Yeah.
Thank you.
Thank you. More questions? Yes, please.
Dr. Savia from Uganda. Thanks to all the presenters. I think it's clear that decentralization will help us to treat most of the MDR-TB patients. I've heard from Swaziland incentives for the DOT providers. From the other countries, what is happening? Are we looking at the people who are giving treatment to the patients? Is there anything that these people are getting? The other one, protection for the health workers in terms of policy. Is there any policy that covers these health workers in case they get MDR-TB? What is there? The other one is about infection control at community level. What are the experiences out there? Thank you.
Thank you. Who would like to volunteer?
The question of incentives to the healthcare workers. Yeah, in South Africa, our decentralization is right within the government sector. So there've not been any incentives because these healthcare workers are full-time employees of government. So they factored this in their work and they receive their salaries. Now, in terms of the risk as well, there's the act, the law, Quaid Act, Compensation for Occupational Injuries and Diseases Act. So this law makes provision for compensation if you are to be injured or infected at workplace. So we use the general mechanism that exists in public service. So there aren't extra incentives or regulations. Thank you.
Thank you. Velili?
Thank you for the question. I actually wanted to respond on the issue of stigma. So in Swaziland, we don't have a compensation system for healthcare workers that are infected, and that is actually contributing to stigma, not necessarily from family and community, but from other healthcare workers towards patients. And I think a lot of the time when we talk about stigma, we think more of stigma at community level without addressing it amongst our healthcare workers themselves. And that is where we are facing a lot of the challenges. So to address that also comes with strengthening of IPC measures and education and re-education, which can sometimes be difficult because healthcare workers rotate on a 6-monthly basis to minimize their exposure to TB, undiagnosed TB patients. But the main concern that we have when it comes to stigma, in terms of IEC, it's always been targeted towards the community at large, but very little up until now has been done addressing stigma at healthcare facilities, which could be a barrier to access for patients.
Thank you very much. So it sounds like a very important topic we all talk about, but little has been done to study it, to measure it, and to actually upon on those findings. So next question, Pedro.
Pedro Suarez from MSH. This is a question for the speakers. Based on your country experience, what is your thinking about the potential benefits to improve the treatment outcomes in terms of the success rate and the cure rate with the introduction of the new shortened MDR-TB treatment that now we will start to implement in several countries?
Norbert, you are courageous.
I think the introduction of new regimen, short regimen, I think is going to be very helpful. I think one of the headaches that you get when you decentralize is to get your data. I'm not sure, it didn't come out very clearly in all presentations, but it's very difficult. If you've been having 2 sites at university level where it works well, or in NGO or in a project, I mean, we all know NGOs are very good with data recording and reporting. When you put it in a small clinic somewhere in rural area, you're not sure about the data. So the headache of getting data is a huge one, but also a lot of our colleagues have mentioned that after 9 months, it's very difficult to keep people who are well on treatment. So I think just that element alone of getting people closer to their homes and shortening the treatment, can help with having complete data, but can also motivate patients to stay. But the drugs are also better when you look. I think 7 is better than 5 if you have to go to details. So I think we should see better outcomes.
Thank you. Any other? There are another pending question before yours. Yeah, go ahead.
Hi, my name is Karina Kielman from Scotland, and I wanted to make a pitch for better health systems research, actually, because what we see from all the presentations as well as the systematic review is that there's variation, there's heterogeneity, the question of, one size doesn't fit all, and it seems to me really important that we have a review of what exactly these decentralized models look like in practice. So that means specific understanding around the information systems, the communication systems, the actual model of care needs better description, and I'm also making a pitch for work that we're doing in conjunction with UCT at the moment, and Dr. Njeka is one of our key informants. I don't know whether you've been interviewed yet, but this is really looking at, in South Africa, understanding that there's huge variation in terms of how the policy is understood locally and mapping the distinction in those models so that we better understand, when we have a systematic review, we better understand the mechanisms for success that we see.
Thank you. Greg, would you like to respond to this pitch?
Yeah. Thank you. I fully support all the points that you've just made now. And just to say that even in the papers that we've included within a single country, between a rural province and an urban province, or even over time, there is variability in the nature of the intervention that's delivered. Just because an intervention initially is successful doesn't mean it will be sustained in a successful way if the initial staff are lost and there's a failure to continue training and retraining. So for programs, monitoring and reporting on exactly what is happening is critical to interpreting the data. And then secondly, your point, I think, is critical around trying to go and look further and get at what is actually going on in each context. And it will help if those who presented today and others can publish their findings and describe in detail what is done, and just continue that conversation around what alternative methods of implementation and evaluation are feasible in those settings.
Thank you. Last question. Feel free to come to the podium if you don't mind, because the mic is well behind.
Okay. Hang on.
Yes, thank you very much. I am from Turkey, Istanbul. Thank you very much for your all presentations. And I would like to ask Greg, this meta-analysis is interesting and is available, I think, decentralization and centralization treatment. But it's not published yet. What about your conclusion?
So the manuscript arising from the review that we did for WHO is currently under review, so I hope that it will be available soon. And the conclusions, I think that I've mentioned a few of them, but again, just to reiterate the importance of trying to go and do well-controlled trials to get a more accurate estimate of the effect of the intervention rather than confounders. Secondly, the importance of getting detailed local data around costs. And then thirdly, the importance of considering the variability of the interventions. So I think they'd be the three factors that I'd say as conclusions.
Thank you.
Okay, I think we are done. Thank you very much. We had a very lively session. I would like to thank the presenters and all the participants and also my co-chair, Ernesto. I think moving forward, I think the major issues came up, like, for example, how do we systematically monitor, measure, address stigma, and how do we also review the health system and looking at this different model, what do they actually mean? So we hope to see better and more rigorous studies for the next union meeting. Thank you very much.
Thank you.